So welcome back everyone. Now we have a session on infectious causes of cancer, preventive aspects by Dr. Rajalakshmi A. And Madam is Senior Consultant, Infectious Diseases, KIMS Health Trivandrum. And to chair the session, I would like to invite Dr. Vasudev Acharya, Professor of Medicine, and Dr. Chaitra Rao, Professor of Community Medicine.
And sexual transmission is infrequent except in select high-risk population, especially HIV positive MSM population. This is a chart which shows that what is the timeline of developing an HCV infection to HCC. That is, when you have exposure to HCV and you acquire infection, it may get resolved. And in about 60 to 65, it causes persistent infection, of which 5 to 20% develop cirrhosis, and 25% of those cirrhotic patients develop hepatocellular carcinoma, that is over a period of 5 years or more. So primary HCC is typically a late complication, and with increasing access to the directly acting therapy, antiviral therapies, HCV is actually curable. Hence, we are looking at prevention of cirrhosis and HCC in the long run. So there are so many factors that can cause or increase the chance of cirrhosis in a hepatitis C positive patient. So when you diagnose HCC, it's important that we treat other factors which can actually result in cirrhosis, not only treating HCV infection, and these include co-infection with HIV. So you have to screen for HIV and hepatitis B, and actually the duration of HCV also is important, so early treatment is important, and other risk factors like alcohol should be taken care as well. So how do you screen for HCV? Do you screen everyone? Because there are some high-risk group who, if you see them in your clinic, you should definitely screen. And definitely these are injection drug abusers. So injecting illegal drugs because of unsafe needle practices, and person with HIV, with MSM, or even otherwise, you have to look for co-infections. And most importantly, the post-exposure testing should happen for all needle stick injury, especially in healthcare settings or even in any other settings, and children born to HCV infected women and sexual partners. Remember, we don't have any post-exposure prophylaxis as such. As per guidelines for HCV as of now, there is no immunoglobulin or vaccines, and PEP is not recommended soon after exposure, but these patients require follow-up for any seroconversion baseline at 6 months, as well as monitoring liver test, and then if there is any transaminitis, you have to recheck HCV. So treatment and elimination of HCV has given a lot of momentum these years, and WHO goal of HCV elimination is by 2030. So what do they target is, if you diagnose 90% of HCV and 80% of the eligible persons treated, to reach a 90% reduction in HCV incidence, and this will reduce HCV-related cirrhosis as well as HCC mortality by 65%. These are the goals that they are looking at, and what has been already started is to focus this HCV elimination in localized population so that you can target elimination, and these are HIV positive MSM, screen for HCV actively, as well as in certain countries where they are moving towards HCV elimination like Georgia. So what are the major barriers of HCV elimination? Is suboptimal diagnostic test, we don't screen much, and poor and variable access to the antiviral drugs, which are very expensive till few years. It is better now. And then there are a lot of coordinated efforts that we need, just like HIV detection. Prevention, reduce exposure to contaminated blood through screening of blood products. It should be universal, as well as in healthcare setting where many of the needle stick injury goes unreported, unrecognized, and even not properly evaluated. And you have to have give safe injection practices for IV drug abusers, and in settings where the sexual transmission is the main mode of transmission, again, barrier protection method should be recommended. As I said, treatment as prevention is done in many areas, including some countries, and certain high-risk population like HIV with MSM. And vaccines is not still in the card. Because HCV undergoes a lot of viral diversity, just like influenza, so the vaccine is not in the market asset. So what is this? So this will come to the HTLV. HTLV is belong to the human retrovirus, and it causes adult T-cell lymphoma leukemia. Again, it integrates into the T cells, host T cell goes into latency, and expansion of infectious burden by proliferation of infected lymphocytes is not the primary cause of lymphoma. It is that is a primary cause of progression to lymphoma than production of free virus particles. This is important because by treating HTLV alone, you are not reducing the incidence or progression to lymphoma. So the latent virus, when the T cell multiplies, this burden increases. So this the best example that is understood is with when you treat HIV, the CD4 improves. So there is lymphocyte proliferation. So that actually causes a clonal rebound of HTLV because the infected cells proliferate. So that is why the treating HTLV will not reduce ATL. Again, if you look at, there are a lot of efficient modes of HTLV transmission, but sadly our blood banks doesn't screen for HTLV. If you look at the best mode of transmission, very efficient, is blood transfusion. And there are other modes of transmission like breast milk, sexual transmission, and transplacental transmission is actually low efficiency. So prevention is, if you HTLV infected pregnant women in middle and high income countries are advised not to breastfeed, but it's not so in developing countries where breast milk may have more protective effect, less like HIV. Infected mother, we advised to continue if their viral load is suppressed. Prevention is by use of condoms and not to share needles. US FDA recommends HTLV testing for all the donated blood, but it's not recommended for donated organs, and no vaccine is currently available. Treatment, no treatment is recommended. Zidovudine and lamivudine have little activity on the HLV reverse transcriptase in vitro, but there is no clinical evidence. Raltegravir has shown reducing the proviral load in vitro, but again, it doesn't have no clinical reductions in the infected individuals. What we usually follow up with HTLV is look for symptoms of myelopathy, physical exam, and a blood count to know whether there is any signs of lymphoma, and general physical exam, because 5% have a risk of developing all these complications. So coming to the next important infection causing cancer, herpes group, Epstein-Barr virus. It's a double-stranded DNA virus. It's enveloped, and it's also known as HHV4. It commonly causes mononucleosis-like syndrome. Again, the replication maximally occurs in oral epithelium, and it establishes lifelong latent infection in B lymphocytes. But it doesn't cause any harm in 95% of the individuals, and in 5% it can progress to cause various forms of lymphoma and cancers. So immunosuppressed host is the main host who can develop all this, and EBV and also the Kaposi sarcoma encode proteins that activate cellular gene expression and B cell signaling pathways. This is the frequency of EBV shedding. If you look at, even if you recover from a mononucleosis-like syndrome, a seropositive healthy adults secrete up to 25% in the oral saliva. And if you are immunosuppressed, your secretion is up to 50 to 100%, and the transmission is through infected saliva. So what are the malignancies that can cause? It can cause several types of lymphoproliferative disorders, Hodgkin's, Burkitt's lymphoma, and nasopharyngeal carcinoma. It also can cause gastric cancer, including maltoma. These are other rare cancers that EBV can cause. It can be related to either B cells or T cells, or infection of non-lymphoid cells. Treatment, antiviral therapy is not beneficial. Currently available antiviral inhibit the lytic replication. Again, it doesn't help because these are latent infection that causes the lymphomas. So they have done experimental treatment to stimulate the lytic replication stage by giving histone deacetylase inhibitor, and then treat the lytic with an inhibitor of lytic replication using acyclovir and ganciclovir, but these are not useful in practice. Prevention. Spread of virus requires intimate contact. So in general, we don't advise any isolation for these patients. Elevated viremia, this is an important thing. Elevated viremia is seen for several months after recovery. So postponement of blood donation by these patients should be advised by any clinicians for the next 6 months. And EBV vaccine, again, is not in the market. So it's another herpes virus, that is Kaposi sarcoma associated herpes virus. And this causes Kaposi's sarcoma and many others carcinoma, and it is HHV8. Again, it is a double-stranded DNA virus. It establishes lifelong infection, latency in B lymphocytes, and replication occurs in oral epithelium, just like EBV. Transmission is predominantly the result of exposure to infected saliva and MSM group. And primary infection is usually asymptomatic and is rarely recognized. So what does it cause? It causes mainly in the setting of an immunosuppression, it causes several forms of cancer. Kaposi's sarcoma has 4 variants, and it also causes Kaposi-associated iris when HIV patients are treated. It can cause primary effusion lymphomas, body cavity lymphoma. It can cause multicentric Castleman disease, which is a rare lymphoproliferative disease. The types of Kaposis is classic, epidemic, endemic, and iatrogenic. Classic usually seen in European descent, indolent, slowly progressing. Endemic is seen in African countries, and classical HIV-associated Kaposi is epidemic, and it is actually can be disseminated into many of the visceral organs, including liver, lung, and sometimes many times carry poor prognosis. Iatrogenic is when the patient is immunosuppressed, they can have these aggressive forms of Kaposi's sarcoma. Treatment, again, antiviral currently only available for the lytic lesion, doesn't help. Enhancing immunity sometimes helps, especially in the HIV setting, so antiretroviral therapy helps. Cytotoxic approach is often necessary for treating as a malignancy, and there is no vaccine currently. Again, this is another virus. This is the last virus I'm going to talk on. Merkel cell polyoma virus. Again, it's a new virus, recently discovered, I should say, in 2008. It is also with human skin disorders and cancers. So it's a rare skin cancer, can be aggressive. It's a deadly neuroectodermal tumor. It principally affects face, head, and neck, mainly sun-exposed area. And again, like HPV, it has got a strong association. It is detected in up to 80% of the tissues of Merkel cell carcinoma. It affects immunosuppressed, and there is no vaccine. Okay, so this again an easy one. H. pylori. H. pylori is persistently colonized human stomach. We have covered viruses, we have come to bacteria, and most of them remain asymptomatic, but it increases chance of gastric cancer. So the 2 cancers that's commonly affected are non-cardiac gastric adenocarcinoma as well as mucosa-associated B-cell lymphoma. Treatment, again, you have to diagnose and treat with antimicrobial therapy. A lot of combination antimicrobials are available, and again, with a lot of resistance, Helicobacter is becoming resistant to most of the combinations, and there is no vaccine. Again, these are the combinations that are available. So this is the last one. Anyone? Flukes, okay? Genitourinary schistosomiasis. It's common seen in Africa and Middle East. So this is the cycle, as you can see. Eggs are passed in the urine and then hatch in fresh water. Meracidia invade small intermediate host, and then in few weeks it forms a forked tail cercariae. These penetrate the human and pass through several cycles, lung, liver, and then final inhabitant is the bladder, venous plexus. Hematuria, dysuria from inflammation and small ulceration happens starting 3 to 4 months after infection, and in endemic areas, by 10 years, most of the children will have microhematuria. That's how it begins, and then later they have developed polyps, nodules, patches, granulomas, calcification, and later on they have a high risk of developing bladder cancer. Treatment is again surveillance and early treatment by praziquantel, and they actually regress the lesions before it turn to be irreversible. Okay, so again, sanitation, provision of clean water, snail control, so many of public health aspects come into. It is not a major problem in our country. So this is a slide summarizing the whole thing. Prevention of cancers is multimodal. Safe sex can prevent a variety of cancers. HPV, HCV, HTLV, and Kaposi. Safe injection among the IV drug abusers prevents HPV, HCV, and HTLV. Safety in healthcare prevents a lot of viruses. by introducing right sharp handling, right PPE, donor blood screening, and disinfection and sterilization policies. So this prevents HPV, HCV, HPV, and HTLV. Prevention of maternal to child transmission during pregnancy, breastfeeding prevents HPV, HCV, HTLV. Screening of early detection of cancers is important. Surveillance is important for HPV, HCV, and HTLV. Vaccines we have for HPV and HBV. Treat early to prevent. Again, we have for HPV, HCV, H. pylori, and schistosomiasis. Restore immunity with HIV. And all these are risk factors for HIV also, though it directly doesn't cause any cancer, but it can be associated. Many of the co-infections are associated with HIV. So I will end with one more slide, which I have missed, I've touched so far. That is tattoo. Tattoo can cause several things. We have in and out daily many people coming with tattoo. Again, it's almost equal to injection drug abuse, I feel, because there's so much of practice of unsafe tattoo. Just before yesterday, I should say, morning, I had a case of HIV with Kaposi. The only risk factor, maybe he denies many things, was tattoo. And he has multiple tattoo all over the body. So you can get HPV, you can get HIV, HCV, HPV. So thank you so much. I will end my talk with that. Thank you.
Thank you, madam, for the wonderful presentation. A couple of questions from my end. You said for the HCV group, people born between 1945 to 65 are at high risk. Any particular reason for that?
No, there was actually not much of screening happening, and that was a peak of HIV, correlating with HIV epidemic. Unsafe drug use as well as MSM, and it all correlates. So screening that population is important. And they may be old now, but they are exposed at that point in time. And even blood donation screening was not stringent at that point in time. That was the commonest mode of transfusion-related HCV.
And then the HTLV-related cancers, is it very common in your clinical practice? Is it worthwhile screening all the people who come to the clinic for HTLV?
It's actually only 5% of HTLV infected develop lymphoma. We don't have much data on the prevalence of HTLV here, because something that I was thinking, and it's a good way to think, is to screen for blood donors, but unless we have a policy as what to do next, we should not be doing it. But in certain countries like Australia, New Zealand, US, they screen blood for HTLV, because the transmission mode is almost similar to most of it, HIV transmission, all these are. So we must be having HTLV. And definitely, if you diagnose HTLV, even if there is no treatment, we should advise for a follow-up every 6 to 12 months, because we have had one patient of HTLV within 1 year developing ATL. So, so that they report, the prognosis is very bad for ATL, so it's important that we tell them what to look for and come for a follow-up.
Would any form of chemoprophylaxis or antiviral treatment prevent the progression of the disease?
No, these are all actually latent virus. So antiviral, most of for EBV, Kaposi, and many other viruses that I have spoken is if the antiviral has not much role. The role of antiviral is for hepatitis B, hepatitis C.
Thank you.
Any other questions from audience? This is actually a very classical theory question for an MD examination. In fact, last year one of the state health university has asked this question. In fact, Kerala Health University only asked this question. And I read before evaluating it, and her last but one slide, I think. That was so good slide, such a nice slide. How to prevent everything she has put. So it so nicely has been put. In fact, I read that. If I read this slide, probably it would have been easy for me to evaluating the question papers. Thank you so much. If there are no other questions, I think we'll move on to next.
Thank you.
May I now request our chairpersons to hand over a memento to Dr. Rajalakshmi as a token of appreciation.